Dr. Pholasith. Dr. Pholasith is the lecturer and consultant of the hepatopancreatobiliary and transplantation surgery unit in Sirat Hospital. Today, he will talk about the prediction of the complexity of the laparoscopic liver resection. Please welcome Dr. Pholasith.
Good morning, everyone. First of all, I would like to thank the organized committee and our esteemed moderator for a kind introduction. And also the IT guy here that Photoshop me look like 20 years ago. Okay. Today I will present the predicting complexity in laparoscopic liver surgery. Then understanding the complexity of this procedure is crucial, not only for patient safety, but also for planning effective training and education for young surgeons. I have nothing to declare. So first, the dealing with laparoscopic liver surgery is like this picture. When you are novice and you try to fight the kill monster, maybe you can win. But if you don't know them well, and you find this, and you don't know that is it difficult or easy, maybe you will fail. And the bad result is not only for your team and you, but also your patient. So maybe you have to upgrade your experience and skill to fight with this opponent. And also in this MESDA conference, other speaker will show you the weapon to deal with it, such as 3D imaging. That's really wonderful for planning, and also any technique or approach specifically for each tumor at any location. So today, first thing we have to know is a difficulty scoring system for laparoscopic liver resection. There's many scoring system nowadays, but I will focus on only major validated scoring system. The first is BAN by Professor Daisuke Ban from TMDU, and also IWATE criteria. Second is Southampton DSS, and third is IMM classification, and also validation of DSS. And also the learning curve, because you have to know that you have experience enough to do that operation. First, before developing the difficult scoring system, the International Laparoscopic Liver Surgery Conference was held in Louisville in 2008. At that time, the experts' consensus suggests that at the beginning of the laparoscopic liver surgery, only solitary and small tumor less than 5 centimeters and located in peripheral area at segment 2 to 6, or the operation such as left lateral sectionectomy is favorable for new young surgeon. And for the challenging cases, which is tumor at location at posterior segments or major hepatectomy, and tumor is large or centrally located or multiple or bilateral, or lesions near hilum and IVC, should be done by only expert surgeons. So later, Professor Ban developed a novel difficulty scoring system for liver resection that include the factor that might affect the difficulty, which is tumor location, extent of liver resection, tumor size, proximity to major vessels, and liver function. From these 5 factors, they can combine and make up to 10 score and make it 10 level index, and can grouping into 3 level index: low, intermediate, and high, and suggest for training and surgery for each experienced surgeons. Follow difficulty, maybe begin for the beginners, and after achieve the successful transformation, maybe they can operate in more complex situation like intermediate level and high level. At that paper, there's also landmarks that patients should begin with a simple and small partial resection of segments 3, and then left lateral sectionectomy, then simple hemihepatectomy or more advanced case if they gain more experience. This is an example of BUN DSS scores, such as a tumor is in the segment 6, small tumor, and do partial resection with the patient in cirrhosis type A. The difficulty score is 3, which is low complexity. And the next is a tumor at segment 4, doing sectionectomy. In tumor is really large, and tumor is close to hepatic hilum in the cirrhotic patient type A. So score is 8, is high complexity. This is an example to use the BUN score. So after that, the international consensus was held in Morioka in 2014. And one objective of that conference is to find the difficult scoring system for laparoscopic liver resection for the safe diffusion of the operation and training. They proposed modification of BUN scoring system and made it into Iwate criteria, which have more details on the hand assist surgery or hybrid surgery that decrease difficulty of surgery, and also grading new score for segment 1 and segment 4 into 4A and 4B. So this is Iwate criteria. The same factors as BUN criteria, but difficulty level increased into 12 difficulty levels and defined as 4 groups of difficulty level: low, intermediate, advanced, and expert. And also recommend the same as the BUN score. And later, after Iwate criteria and Morioka conference, Iwate criteria became more globally recognized as a standard assessing the difficulty of laparoscopic liver resection. This system is pivotal in improving patient safety, surgical outcome, and structure training worldwide for safe expansion of liver resection. So later, there's a lot of many studies to validate the Iwate score for safe hepatectomy. Many studies, such as a single center in Japan, they find that Iwate score correlate with operative time and blood loss, but not mortality and length of stay, because laparoscopic liver resection has a very low mortality and short length of stay also. And so in multi-center Japanese survey, do this again in almost 2,200 patients in 74 Japanese centers, and found that this score correlated with conversion rate, operative time, estimated blood loss, which can show complexity of liver resection, and also post-operative complication and length of stay, which is the outcome of liver resection. This Iwate score also validated worldwide such as in Singapore and United States of America, almost 400 patients from 2 centers. This score correlates with the operative time and estimated blood loss. Also, blood transfusion and Pringle times. There's more and more validation of this EVA score that they can be used for structure training and monitor the progression of quality of the surgery. In later era, I mean near 2020, more and more difficult case was performed by surgeons. And from the recent meta-analysis all over the world, almost 20,000 cases of laparoscopic liver surgery, EVA score correlate well with the operative time and open conversion, and also postoperative outcomes such as postoperative morbidity, major complication, and 90-day mortality, which is increased corresponding to high complexity of the EVA score. By the way, there's some difference between Western and Eastern disease, because in the Eastern, we have patients with hepatitis with cirrhotic background, and the more prevalent disease is SCC. But in the Western country, there's more patients with obesity and high BMI, and also high incidence of colorectal liver metastasis. So maybe this this score maybe cannot show the difficulty of the surgery in Western. So there's other difficulty score in Southampton and in Institut Mutualiste or IMN in France, Paris, was conducted. First is a Southampton score. They have a survey for the expert HPV surgeon, AD surgeon, and almost experience of 7,000 lap liver resection. And they found that more than tumor location, tumor proximity to the vessel, like EVA score. They also consider that the patient with BMI more than 35, neoadjuvant therapy or repeated liver resection or concurrent procedure also make the difficult operation. So it should be included in the score. And after that, they developed the score and found that the neoadjuvant chemotherapy and previous open liver resection has a significant predictor of the difficulty level. And as you can see that previous ovulation, patient will get more 5 points for the ovulation. That the Dr. Chairat showed us that the port position is affecting the ovulation, because sometimes when the patient have a lot of adhesions or colostomy, that can make our port position much difficult, and it affect the operation. This data is from 7 European centers, almost 2,800 patients. And the good point of this score is because it's correlated well with intraoperative risk factor. If patient has a more score, they will have more intraoperative complication. So they suggest that for the surgeon that have low experience, they should begin with low difficulty score, and then when they get more confidence, they can move to more complex city of liver resection. For the IMM classification from France, this scoring system is more straightforward, and objectively measurable criteria. They use the operative time, but loss and conversion to make it practical and less subjective. They divide operation into S operation, so you don't have to calculate the score, but you know that what is the operation that you will do in this patient. And from this operation, they can classify into 3 groups. Group 1 is a with resection and left lateral sectionectomy. Group 2, anterolateral segmentectomy and left hepatectomy. Group 3, posterior-superior segmentectomy, right posterior sectionectomy, right hepatectomy, central hepatectomy, and extended right or left hepatectomy. After classifying into 3 groups, there was a significant difference in the outcome. Patient in the group 1 has less morbidity and complication from the operation. So for the recommendation from this classification, they suggest that young beginner should begin with group 1 and then move to group 2 and group 3. And because this score have only 3 score, in the group 3, they are also different in the complexity between the operation inside. Right posterior and central hepatectomy or extended left has more morbidity and mortality and major complication than right hepatectomy. For the scoring system and prediction of post-operative complication, all of the score can predict well, but EVATEC criteria has a base for prediction of major morbidity. For the systemic review of this score, you can find in this journal, but I have no time to explain each score. Next, you have to know your learning curve. The learning curve has 4 phases: competency, proficiency, early master, and full master. At the first, you have competency, you have develop your skill in laparoscopic surgery, usually in first 20 cases. But after that, when you're confident, sometimes you too confident, you do the very high difficulty level. And that time, on the proficiency state, this complication will occur more than often. And that is not good. And then you will go back and take a look at the complication, and then you step down to the intermediate or expert level, and then you can gain more confidence because the complication is lower. And that is usually after 30 cases to 60 cases of liver resection. In the proficiency state is a warning shot for you that you have to make it slow. Don't rush because complication will go too high. And learning curve for the laparoscopic liver resection for the low level and intermediate level is about 20 cases or 30 cases. And for expert level, it's about 50 to 60 cases. So my conclusion is predictor of difficulty is important to selecting appropriate case according to surgeon experience in liver resection. And also it can estimate post-operative complication in more difficult cases. So training should be structured and stepwise from low, intermediate to high level. Thank you.